Radiologic visualization of anatomy. So the easiest way, quote unquote, to visualize anatomy is to look at it with your own two eyes. You can intervene surgically. Cut open, and if you want to see the bowel, for example, you can perform a laparotomy, cut open the abdominopelvic cavity, and lay eyes on the bowel. That's typically referred to as an open surgery, where you're just sort of making a big incision, opening up the body, and looking in with your own eyes. More recently, as in the last like 40 or so years, we've developed a lot more minimally invasive techniques, less invasive techniques like endoscopy or laparoscopy. An endoscopic procedure sometimes requires an incision, but often does not, and it involves sticking a camera into somewhere. So you may stick a camera down somebody's esophagus to do an esophagoscopy. You may put a camera down somebody's throat to look into their bronchial tubes, which will be a bronchoscopy. That oscopy at the end refers to sticking a camera in somewhere and doing endoscopy. Sometimes you are going to need to cut into a place. For example, if you're going to do a laparoscopy, that's an examination of the abdominopelvic cavity. There's not really a natural way to get in there exactly, so you're going to need to make a small incision to get in and see the inside of your abdominopelvic cavity. Sometimes you may do surgery at the same time while you're looking with the camera, but you'll use different ports. So in a laparoscopic procedure, I'm running out of room. Let me erase some of this. Here's somebody's belly. There's their belly button, crotch, legs. This is roughly where their hips would be. What you might do is make a small incision here for the camera and another small incision over here for instruments that you'll use surgically to cut, to clamp, to inflate the abdominal cavity, etc. You can also go in and do biopsies at the same time. So for example, if you're doing an esophagoscopy or a bronchoscopy, let's say, you're not going to cut inherently to do that. You're going to stick a tube down somebody's throat into their bronchial passages and see them. There's no cutting involved in that. But while you're there, if you see diseased tissue that you want to be able to characterize, you may then also bring in surgical tools through the same passage to take a sample of tissue for examination for pathology. Taking a little sample of tissue for examination is taking a biopsy. So that would be an example of a diagnostic endoscopic procedure. You may go in and repair something. So for example, if you know that there's a hole somewhere along that length, you may go in with a camera, find the hole, and then stitch it up through this minimally invasive technique as well. I already kind of touched on this, a biopsy. This is where you take a small sample of presumably pathological tissue or just weird looking, suspicious looking tissue for diagnostic purposes. This might be done open. Like I said, you go in with an old school surgical approach, big incision, open it up, look in with your eyeballs, or it could be done endoscopically depending on where this the lesion exactly is. Surgeons will always take the path of the least invasive path. If something can be done endoscopically and still be done thoroughly, they'll try to do it that way. If you go in endoscopically and you find that things are just, it's too much, you need to see more, you can always convert that to an open procedure. You can't really do it the other way around. Once somebody's opened up from stem to stern, you can't just, putting a camera in there isn't going to help anymore. So they'll generally try to do it the minimally invasive way first. Another way, aside from a traditional cut, go in and pick something out, to take a biopsy involves a needle biopsy, where what you can do is use a very large bore needle. You puncture the skin just like a regular needle, and you extract tissue. This works well with less firm tissues, bone marrow, for example. This works well with. Skin biopsy, they use like a punch technique where it's almost like a little mini 3-hole puncher that you go in and you can take a sample. It's got like a scoopy claw thing. I guess it looks more like a cross between a 3-hole puncher and, like those claw machines at the at an amusement park or something, where you have to find the little teddy bear and get it into the slot, but it never works. It looks like a combination of those things. It goes in, takes a chunk, and pulls it out. All the only the unifying theme with all of these, though, is that you're going in to take a sample and sending it off for examination for pathology. Non-invasive techniques include x-rays. So nobody's cutting into you, nobody's invading your body to do this, although we are blasting you with radiation. How this basically works is you blast radiation at a structure, and depending on whether it hits something or not, it may bounce back. If it doesn't hit something, it just passes right through. The more densely packed the atoms are, whatever atoms they are, it doesn't matter, the more densely packed the atoms are in that structure, the more rays are going to be bounced back, and the denser it's, the whiter it's going to look. So on X-rays, white equals more dense overall. Again, it doesn't tell you what it's made of, it just tells you there's more densely packed stuff there. And black equals no stuff. And then shades of gray is varying degrees of density. So this is a hand, right? Bones are hard. They're hard, they're dense, so they are very, very white. You can see between the bones where there's cartilage and fluid, there's a space right in here. That's less dense, and so it appears gray. The skin and muscle of your hand, all this stuff around here, less dense than the surrounding tissues or than the bones, so it looks less white than the bones. It looks a little more gray. You have areas where you have more tissue overlapping one another, which ultimately creates more stuff, more obstruction for those rays, like here on the palm or the thumb pad here of your palm. That looks a little whiter than the rest of the palm if you look closely. You can see a little bit of an outline of a fingernail where the gray, you can see like around the edges where the tissue is overall thinner, so there's less stuff, so it's less dense. Where you have, so it's less dense there and it looks a little more gray. This is a really good approach for a lot of reasons. It's good for detecting anomalies where density differs. If you have a tumor in your lung, the tumor is denser than the lung tissue. Lung tissue is practically nothing but air. That looks like just black for the most part, or very, very, very light gray. If you have anything at all going on in the lung, a big blood clot, a tumor, something like that, it's going to show up a lot whiter. This can show that very clearly. It's good for detecting anomalies where space is encroached upon. So if you know that an open cavity should look like this, and all of this in here is black, but instead you see a shape like this, and that's black, you can tell there's something growing in this area. It's encroaching on that open space. Another advantage is it's cheap. This is old technology. It's very, very inexpensive. It's portable. It requires relatively little infrastructure to run. It's a simple process to produce. It doesn't require as much intervention, as much technological knowledge to develop the X-rays as it did way back when. It's done digitally now. It's very easy to do, relatively speaking, of course. So it's one of these things where if you can get away with an X-ray, it's worth trying to get away with just doing an X-ray. It saves time, it saves resources. You don't need the most sophisticated people, most educated people to interpret them. You do have to be a radiologist, but you don't have to be the best in the world to interpret an X-ray. It's a really good approach. It's very clear. The major downside is it does expose your patient to radiation. Now, the amount of radiation that you're actually exposed to by any given X-ray is very, 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 very small. You're exposed to way more radiation by flying in an airplane, for example. So it's not like getting a few X-rays over your lifetime is going to be all that damaging for most of us. But it is something to keep in mind. You don't know what's going to happen later in your life, and you might find yourself in a position later on where you're going to need a lot of X-rays, or a lot of CT uses similar technology, a lot of CT scans. That radiation exposure is going to accumulate and increase your risk for cancers. So for most of us, the X-ray radiation isn't a big deal, but you don't know if it might become a big deal later on. Here's another example of an X-ray. So this is of somebody's foot. You can see the long bones of their feet here. Here's where their toes start. These are your ankle and heel bones up here, all right, just to orient you. Take a moment and see if you can figure out what's wrong with this picture. Remember, bones are dense, therefore they look very white. Less dense areas where you have flesh instead of bone, where you have gaps between bones, are going to be more gray. Take a moment, look at the picture, tell me if you can see anything funky. Okay? There's two things that stand out to me that you shouldn't need to know anything about the bones of the foot to be able to deduce, except for what I just showed you. First of all, what the heck is that guy? You have this like pebble thing sticking in there by your foot. That looks weird. Now, as it turns out, that kind of thing is totally normal, but it doesn't look like the other bones, so it's something that should attract your attention. Another thing is right there, that big crack in that poor person's foot bone. This is a metatarsal. So again, not your toe bones, but those long bones inside of like the bulk of your foot. This is the pinky toe side, the fifth metatarsal side. And you clearly have, poor person, a nasty crack in that bone. They have a fractured fifth metatarsal. You could do more sophisticated X-ray techniques. You could have opened up the foot to see this, but this is a great, quick, inexpensive, non-invasive way of identifying that fracture and identifying the severity of that fracture to figure out what the best course forward would be. Here's another example. Remember, less dense places are black, more dense is white. So ribs, sternum are white. Organs, like the heart, are grayish. The lungs overall, I mean, like I said, the lungs are practically all air. They're going to be mostly black. This is healthy. This is not healthy. Take a moment and look at these pictures and tell me how you might be able to tell that the left X-ray, the lungs of the left X-ray are less healthy. Just to keep reminding, this is less healthy, this is more healthy. All right, so what's wrong with this picture? In the right-hand picture, you have a clear outline of a heart and the major blood vessels and stuff, and bronchi and whatever that are in the region that are coming off of it. The trachea and the sternum is fairly dense. The ribs look normal, and the lungs are just big and open and black as night. They are dark. There is nothing in there practically except for air. The actual tissue of your lungs is minimal. Over here, you can still see the ribs just fine. You can see where the sternum would be. Here's more ribs. But then in here is just like bleh, right? You can tell where the heart ought to be, where you should be able to see the heart clearly, like in here-ish, because you know where it ought to be based on here. But then you have all this extra hazy, cloudy nonsense going on, and it extends pretty far into the lungs. And this is an x-ray of somebody with pneumonia, really severe pneumonia. Liquids are more dense than air, right? So they're going to show up more densely than the air of your lungs. See, this part of the lung right here has nothing but air in it pretty much. Over here, this has some kind of fluid. Maybe it's blood, maybe it is some sort of serous fluid, maybe it's whatever. You can't really tell what fluid it is exactly, but you do know that it is encroachment by something that's denser than air. Okay, and here's another x-ray. I'm just going to go point out what's wrong with this picture. Here's your vertebrae, that's your spine, yay! Here's your hips, here's your ribs, all through here. All this black stuff in here, this is actually your intestines, empty intestines. Your intestines, especially your small bowel, produces gas. The bacteria, as it's consuming some of this stuff, will, burp itself, its waste. It creates gas. That's going to fill your bowel to some extent. And you'll see those air pockets all over the place. So all sort of in here is your intestines. What this person has is something more dense than intestines or bone or air or fluid in their intestinal tract, and that is the nail. Now, based on the x-ray, you can't really tell if the person swallowed the nail or if they got shot in the stomach with a nail gun and it just happened to lodge there. You'd be able to tell when the patient walked in, but the x-ray doesn't deduce that. It just shows that there is this nail in this area of the body, somewhere in the front to back area of the body. In this case, the person swallowed a nail. Why? Well, that's don't know. CT scan is really like a glorified x-ray. So an x-ray is just a 2D image from one perspective, one shot. It's like a photograph, right? A CT scan takes that same regular 2D photograph, but it does it across multiple planes. So if this is a person's head and their neck, you might take a CT scan that shows this plane of tissue, and then another that shows here, and then another that shows here. And you're kind of focusing the x-ray at varying depths along that 3D structure, and so forth and so on. Input all of those images into a computer, and the computer can assemble all of those together into a 3D image that you can scan back and forth through. It's really cool. I highly recommend that you go through and click on these links. They should be functional in the PDF slides. That'll take you to Radiopedia, and you can scroll through the different planes of these different CT scans. So you can see how each individual image of the CT is a regular old 2D photograph, but you can flip through and find where there are problems by scanning through those images. And what's great about that is because, let me draw that person's head back here again real fast. Here's their head. Whoops. Okay, if they have a tumor here, if you were to just take an x-ray of their head, let's look at it from a front view of their head, here's their nose, you would see a circle here for the tumor. You don't know, based on that x-ray, if it's in the very front of their head, if it's in the very back of their head, or if it's smack in the middle of their head. A CT scan can show you, because you're taking all those planes and assembling them together, just how deep it is, when it starts, when it stops, how high up it goes, how low it goes, and then if it has some nasty little offshoot trail of malignancy, you can also see that really clearly, where it is, where it goes, and what path it's following. So it gives you just a more robust 3D perspective on a structure of the body. You do this a lot with the head because it's round and everything kind of looks, it's hard to really do a good characterization of a round thing with a flat picture. Now it is just a bunch of x-rays put together. So what that means is that you have the same con as an X-ray, which is more radiation by quite a bit. All right. An X-ray in and of itself, just a regular X-ray radiograph, requires less radiation than a CT. But your composite image is a lot more informative than an X-ray. So depending on what exactly you need, you may want to suggest a CT scan over an X-ray for your patient. Another consideration is not globally, at least not all facilities have a CT machine. Most hospitals in the United States do. We are very, I wouldn't want to say sophisticated, because there's other countries that have just as sophisticated medicine as we do, but they don't have as many CT scans. We're very profit driven and appearance driven, so hospitals are highly incentivized to invest in all of this technology so they can say, we have all these CT scans, we have scanners, we have all these MRI machines. It's an advertising point as much as anything else. But it is more expensive. It can be claustrophobic to do. It takes a little bit more time. It exposes the patient to a lot more radiation. But again, it is more thorough. An ultrasound, or if you're performing diagnostic sonography, involves sound waves. So what you're going to do is you have a transducer right here that emits sound waves, boom, 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 and then when it hits stuff, the sound waves bounce back, and it also picks up those sound waves. So that transducer is a two-way structure. Because it waits for stuff to bounce back, it's good at detecting where solid things are, of any kind. It's sending these signals and picking them back up in real time so you can see movement. Here, it's really popularly done with in pregnancies to look at the fetus, because sound waves don't hurt anything. It's not radiation, right? So as this is sending signals and feeding them and getting them back and sending them and getting them back, if the baby moves his arm, I say he, it's not always a he, of course, but I have two sons, so I default to he. You can pick up that change really quickly and see it all reflected on the screen. It's great for creating moving images. You can also, most ultrasounds have a way of detecting blood flow as well. You can do 3D images. Some ultrasounds have a way of turning this sort of 2D static image into a, I think, kind of freaky looking 3D image, which can be really rewarded, especially if you're looking for anomalies. It is mobile. It is really cheap. It involves no radiation. Ultrasounds are great, particularly for radiation sensitive experiences like in a pregnancy. Two major drawbacks is its scope of view is limited. So this is the transducer and it's handheld, and the sound waves, when it's emitted, go out like that. If you want to see something over here, you have to move the transducer so that it's facing like this, and even then your scope is limited to that. So you can only see a certain section at a time. Also, it doesn't work very well if you have dense stuff in front of the thing you want to see. So in this instance, you want to see the baby, okay? Baby is more dense than the amniotic fluid or the amniotic sac around it. It's more dense theoretically than your stomach muscles, which are now stretched super, super thin, than the fat layer. So you should be able to see it quite clearly. But if this patient, see this yellow layer is fat, if this patient had a thicker fat layer, you'd have a lot more stuff for those sound waves to travel through, and so you're going to get a fuzzier image. It's going to be harder to get an image. If you were looking at something that's behind bone, you're not going to see it at all, because the sound waves are all going to bounce off the bone and they're not going to make its way through. Please look at these examples. Again, those links should be working with the PDF. An MRI is similar to a CT scan in that it takes a bunch of planes of something and then assembles them into a 3D image. But in this case, it uses magnetic fields instead of radiation. And instead of looking at overall density, it reacts specifically to the density of hydrogen atoms. So things that are dense in hydrogen atoms are a lot of liquids in your body, H2O, there's two H's in every water molecule, right? So liquidy areas, fatty areas tend to be very dense in hydrogen atoms. Drier things on the whole, like bone, are less dense with hydrogen atoms. Bone is overall more dense than, say, your fat. So in an X-ray, it would show the bone as being denser than fat. But in an MRI, since the fat has more hydrogens in it, that's going to show up brighter and whiter than the bone. A good example right here is the skull. So think about your skull. You have this hard skull, crunchy exterior with squidgy, less dense middle, and your eyeballs are less dense than your skull too, right? So in a regular X-ray, your bone would show up white, and the middle stuff and your eyeballs, shades of gray to black. In an MRI here, look at the eyeballs. Eyeballs are filled with liquid. Liquid is high in hydrogen atoms. They show up bright, 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 bright white. You have fat here between your bone and your skin. That shows up whiter. You have liquid in the middle of your brain. You have all sorts of cells through here, like cell bodies of stuff on the outside of your brain. That's going to show up later than the inside, which is mostly just like the tails of those cells and the axons. So it's almost like an inverse image of an X-ray, but it does look at a different thing entirely. So don't get those confused. Because an MRI doesn't use radiation, it uses magnetic waves, you can afford to take a lot more pictures. And so you can be taking these pictures, interpreting them, and then sending out more magnetic rays or more magnetic fields to get more bounce back, to look at more images all the time. Because you can constantly be sending the signal and receiving it back and sending the signal and receiving it back, and you're not worried about dosing your patient with radiation, you can create effectively a moving image. This is extremely precise. This is extremely detailed. Unfortunately, getting an MRI, for those of you who haven't had one done, it is a loud experience. It's claustrophobic. It takes a long time to even do a simple MRI. It's extremely expensive to do, both for the patient and for the hospital. These are all pretty big cons, some more so than others. Claustrophobic can be a real issue if your patient is large and it's extra tight in there. If you have a child who's already kind of scared going in there. If the loud part can be really scary to a child as well. If you have somebody who's fidgety, I guess again like a child, it can be hard to be in such a cramped little space if you're kind of a fidgety person and hold still like that for that amount of time. It's easily damaged if you introduce metal to the experience, because you're using magnets, so metal and magnets don't always go great. If you have a patient who has a lot of metal in their body, you're not really going to want to do an MRI so much. There's a variation of this called an fMRI, a functional MRI. The F is for functional, which does the same sort of thing, but it also looks at blood flow in real time. Okay? Again, please look at the examples provided here. Finally, positron emission technology, or a PET scan, is a way of detecting metabolic activity. So this isn't a density thing now. X-ray, CT, ultrasound, MRI, all had something to do with density. This does not. What's going to happen here is you're going to introduce something into your bloodstream. You're going to attach a radioactive tracer called a radionuclide into the bloodstream attached to something that your cells take up. So some glucosey thing usually, right? The cells that are living and active and happy and doing their regular stuff is going to take up that thing, that biologically available substance, again, usually a glucose something or other. And since you have a radioactive component attached to it, it's going to take up the radioactive component as well. And then you can look at the region of the body into which you've introduced this radionuclide and detect the gamma waves that are emitted from the radionuclide. So basically what you're doing is you're attaching a tracer to something your cells take up. If your cells take it up, you're going to get more of this gamma wave bounce back. If your cells aren't taking it up and there's not much metabolic activity, you're not going to detect much of this radionuclide. This is a good way of determining what cells are happy and living and active and which ones are not. A popular scan it's a popular way of using PET scans are in the head and the brain. So this is the example I give here is to determine how conscious somebody is. If you have a person who is fully conscious, you'll have scans that look like this. You have brain cells that are mostly on sort of the outside of your brain that are taking up this substance, consuming it. It's taking up the radionuclide, and you can detect a lot of this radionuclide activity. The red stuff is very active. Greens and blues are less active. If somebody is minimally conscious, like in a not vegetative, but in a coma, for example, it'll look more like this, where you have these cooler greens. You don't really see reds and yellows anymore. And over here is somebody who's in a vegetative state. Their brain isn't really doing anything at all. There's no metabolic activity or very, very, very minimal metabolic activity. And so you don't see as much of the bounce back of this radionuclide, the gamma waves from the radionuclide. This is very, very clear. This is very precise. It's kind of unreplaceable. The other means of intervention don't look at metabolic activity directly. You can only hope to infer it by blood flow. This is a direct visualization of whether or not the cells are doing stuff or not. So it's clear, it's precise, but it's extremely expensive. A lot of hospitals just plain old don't have it. You might have to go someplace special to get this type of thing done. And it does expose the patient to radiation, although it is at an extremely low level. Please look at these examples. That concludes our radiological interventions or radiological ways of visualizing anatomy.